Hello, my name is Sergey Motov. I'm an emergency medicine physician at Maimonides Medical Center in Brooklyn. And today, I am going to talk about lidocaine for pain management in the emergency department. I have nothing financial to disclose. And particularly for today's talk, I am going to touch on two entities of lidocaine being systemic analgesic. I am going to talk about the role of intravenous lidocaine for treating a variety of painful conditions in the emergency department. And I'm going to talk about the role of intra-articular lidocaine injections for pain control and reduction of dislocated shoulders in the emergency department. Why is this topic important? We do all know that in situations with patients when they have let me rephrase this again. Why is this topic important? We are all aware that patients in extreme of ages and patients have multiple comorbidities will suffer undesirable complications when receive systemic opioids. In addition to it, patients with chronic debilitating painful conditions are tolerant to opioids. Thus, any increase or any attempt on our behalf to give them more opioids will not provide additional analgesia, but will result in side effects such as hypertension, disorientation, altered mental status, dizziness, and respiratory depression. With respect to procedural sedation, which we accustomedly use to reduce dislocated shoulders in the emergency department, it's not without the risks. Patients do become hypertensive, patients do become respiratory depressed, some of them aspirate even. And when it comes to procedural sedation, it's very time and resource consuming. On average, it takes somewhere between 2 to 3 hours to put everything together. Plus, patient stays longer in the emergency department in the recovery phase. For that very reason, lidocaine, based on the data I'm going to talk to you about, seem to be as a viable option to control certain painful condition and to use as a local intra-articular analgesics to control pain and ease up reduction for dislocated shoulders in the emergency department. Before we go any description of the evidence, let me refresh your memory with respect to how does lidocaine work. We all know that lidocaine is a Let me rephrase this. Lidocaine blocks voltage-dependent sodium channels. Every cell in our body acts with respect to depolarization. Nociceptors are not an exception. Thus, by blocking the sodium channels, nociceptors, known as a pain receptors, will not transmit a painful stimuli up to the sensory pathways into the spinal cords. In addition to it, lidocaine reduces transmission in those sensory pathways, decreases or inhibits ectopic discharges from the injured nerves, and decrease amount of central pain and deafferentation. When should we use lidocaine? Based on the studies of chronic pain, cancer, and even postoperative pain, lidocaine as a systemic analgesic given intravenously in the form of infusion has been extensively used in patients with opioid-tolerant pain, patients with chronic pain syndromes, patients who are analgesic resistant, and with respect to well-known properties of lidocaine, has been extensively used as a local, as analgesic, part of the regional anesthesia, and here, for this particular talk, we're going to use about use of lidocaine as an intra-articular analgesic. Let's talk about the intravenous lidocaine first. When should we be using it? In patients with neuropathic pain, post-operative pain, patients suffering from post-herpetic neuralgia, patients suffering from chronic headaches and malignant pain. Intravenous lidocaine, once again, given in the form of infusion over 2, 4, or 6 hours, has been shown, has been studied to bring appropriate relief or significant relief to patients. Lidocaine is such a short-lived medication that its side effects are transient and rapidly reversible. When it comes to mild side effects of lidocaine, periorbital numbness and perioral numbness are more prominent. Some of the patient may experience dizziness and vertiginous symptoms, and some of the patient may have transient dysarthria. In the case of severe anaphylaxis or severe adverse effect induced by lidocaine, cardiovascular collapse will ensue due to either severe arrhythmia or true anaphylaxis. Let's talk about role of intravenous lidocaine in acute pain management in emergency department. One of the First studies that evaluated analgesic effect of intravenous lidocaine came out of Iran. Dr. Solomon Poor and colleagues published a case series of 8 patients with a mean age of 35, 6 men and 2 women, who presented to emergency department with a flank pain consistent with renal colic. Patients were given 1.5 milligram per kilogram of 2% lidocaine, not to exceed 200 milligram dose intravenously over 5 minutes. Primary outcome, change in the pain score from the baseline to 30 minutes. And results showed there was significant or drastic change in pain score at 10, 20, and 30 minutes. 6 patients out of 8 had nearly complete resolution of pain at 10 minutes. 7 patients out of 8 had complete pain relief at 20 minutes, and 7 patients out of 8 had complete pain relief at 30 minutes. Average change in pain score was by 7 points at 30 minutes. 2 patients, unfortunately, experienced mild dizziness, and 3 patients had minimal slurring of the speech that resolved within 2 to 4 hours after administration of lidocaine. Subsequently to this study, Solomon Poor and colleagues conducted a prospective randomized trial comparing intravenous lidocaine given at 1.5 milligram per kilogram to intravenous morphine at the dose 0.1 milligram per kilogram given to a patient presenting to the emergency department with renal colic. 120 patients were assigned to each group. Primary outcome of the study, change in pain score at 30 minutes. Results showed, as you can see on the table, patient had similar baseline characteristic with respect to a pain score. However, throughout entire study time, from 5 minutes to 30 minutes, group of patients who received intravenous lidocaine had significantly statistically larger or better change in pain score in comparison to a group of patients who received intravenous morphine. Thus, at 5 minutes, change in pain score was 65% for patient in lidocaine group compared to 33% in patient in morphine group. When it comes to side effects, 87% of patients in lidocaine group in comparison to 87% of patients in morphine group had no side effects. Most prominent side effect in lidocaine group of patients was dizziness, and the most prominent side effect of patient in the morphine group was nausea. Thus, author concluded that lidocaine given intravenously at 1.5 milligram per kilogram is viable alternative or even superior alternative to morphine in treating pain of renal colic in patients. Let's look at the lidocaine, whether or not systemic lidocaine, known as intravenous lidocaine, can help patients with migraine headache. Rutens and colleagues conducted a prospective randomized double-blind study of 25 patients, 13 of whom received intravenous lidocaine at 1 milligram per kilogram, intravenous push, and 12 of patients received normoxilin as a placebo, intravenously as well. Primary outcome of the study, change in pain score at 20 minutes. And results showed that at 20 minutes, the pain intensity was 80% of initial intensity in intravenous lidocaine group in comparison to 82% of initial intensity in normoxilin group, which means, in simple words, none of the patients received appropriate pain relief and the change in pain score was essentially identical. Author's conclusion, at the dose studied, lidocaine at the best provide modest relief in patients with acute migraine headache. Taken further, Bell and colleague conducted a prospective trial or comparative trial of 3 agents, of 3 analgesics, with respect to their analgesic efficacy in treating acute migraine headache in the emergency department. 76 patients were enrolled in the study. 26 patients received intravenous dihydroergotamine at 1 milligram given intravenously, with the second dose of 1 milligram to be repeated at 30 minutes if headache still persists. 24 patients received intravenous chlorpromazine given at 12.5 milligram intravenously with similar dose every 10 minutes up to 3 doses and up to 37 milligram maximum dose. 26 patients received intravenous lidocaine at dose 50 milligram as a single IV push with subsequent 50 milligram pushes every 10 minutes up to 150 milligram total dose maximum. Primary outcome, change in reduction of headache in change in the pain score at 1 hour post-enrollment in the study. And results showed that chlorpromazine did significantly better than dihydroargotamine and lidocaine. Most importantly, though, when it comes to percentage of patients who received relief from persistent headache, only 29% of patients in lidocaine group had acceptable relief in comparison to 50% in dihydroargotamine group and to 89% of patients in intravenous chlorpromazine group. Now let's look at the patient who suffered from post-herpetic neuralgia. Baranovsky and colleagues conducted a prospective randomized trial of 24 patients who were given normosaline placebo and lidocaine at 2 different doses. One group received lidocaine at 0.5 milligram per kilogram per hour. Second group received lidocaine at 2.5 milligram per kilogram per hour for a 2-hour period with attempt to evaluate whether or not lidocaine would work better than placebo with respect to change in the pain score and rates of allodynia in patients suffering of post-herpetic neuralgia. Results showed that lidocaine groups did significantly better than placebo with respect to controlling pain and reducing allodynia. However, group of patients who received larger dose of lidocaine at 2.5 milligram per kilogram per hour had significantly less amount of allodynia in comparison of lower dose of lidocaine, but both groups had similar change in pain score, tested as a pressure-provoking pain. Lastly, just recently, Tannen and colleagues published a prospective randomized double-blind trial of 41 patients who presented to emergency department with acute radicular lower back pain. 20 patients received 100 milligram of intravenous lidocaine, 21 patients received 30 milligram of intravenous ketorolac. Primary outcome, change in pain score at 15, 30, and 60 minutes. Initial pain score were essentially the same, 83 millimeters on visual analog scale for intravenous lidocaine group and 80 for intravenous ketorolac group. At 60 minutes, change in pain score was significant for intravenous lidocaine and intravenous ketorolac. However, there were no really truly significant changes between 2 groups with respect to change in pain score. In addition to it, almost 70% of patients in intravenous lidocaine require rescue analgesia in the form of opioids, compared only to half or 50% of patients in intravenous ketorolac group. Let me summarize a study so far. Intravenous lidocaine has limited data for acute pain management in the emergency department. And one case series, one prospective randomized trial did show that intravenous lidocaine has some merits in treating acute renal colic in patients who are either opioid tolerant or, on behalf of practitioners, opioids are not warranted. If you decide to use lidocaine intravenously, use 1 to 1.5 milligram per kilogram dose of 1 or 2% lidocaine that is given over 5 to 10 minutes. Do not give lidocaine as an IV push dose. And ultimately, we do need more robust data, more controlled, randomized, double-blind trials in evaluating truly analgesic efficacy of intravenous lidocaine in treating a variety of painful conditions in the emergency department. Now let's talk about the role of intra-articular lidocaine for pain control and ease of reduction in patients presenting to emergency department with acute shoulder dislocation. One of the first studies was done by Kosnick and published in 1999. It was prospective randomized, non-blind trial of 49 patients who were randomized to receive intra-articular lidocaine or intravenous analgesia and sedation. 24 patients were randomized to receive intra-articular lidocaine and 25 patients intravenous analgesia and sedation. Primary outcomes, change in the pain score prior to discharge, ease of reduction, and overall satisfaction. Results showed that there were no truly significant difference between change in the pain score between group who received intra-articular lidocaine or intravenous analgesia and sedation. Reduction scores were slightly better for intravascular analgesia and sedation. However, 50% of patients in intra-articular lidocaine group who had experience with intravenous analgesia and sedation stated they would rather prefer intravenous analgesia and sedation. Taken further, Fitch and colleagues published a systemic review of available trials in 2008 with respect to comparison intra-articular lidocaine to procedural sedation or intravenous sedation of opioids and benzodiazepines. Result of the systematic review showed that there were no difference in success rate with respect to reduction between lidocaine and intravenous sedation groups. However, intravenous sedation group had higher complication rate and definitely had a prolonged length of stay after the procedure. Similarly, VISCERAL and COLIC conducted Cochrane database systematic review in 2011 evaluating role or analgesic efficacy of intra-articular lidocaine in comparison to intravenous analgesia and sedation with respect to shoulder reduction. Results resembled similarly study by Fitch that showed there were no change in immediate success rate between intra-articular lidocaine or intravascular sedation and analgesia when it comes to success of reduction. However, intra-articular lidocaine group had significantly fewer side effects and length of stay was significantly shorter in intra-articular lidocaine group. Waterbrook lastly published clinical review that demonstrated that group who received intra-articular lidocaine for shoulder reduction had significantly less complication rate, length of stay, and cost in comparison to patients who underwent procedural sedation. However, study by Hames showed things slightly different. Hames and COLIC conducted a randomized prospective double-blind study evaluating analgesic efficacy, length of stay, ease of reduction, and patient satisfaction of patients presenting to emergency department with anterior shoulder dislocation who were randomized to receive intra-articular lidocaine given at dose 4 mg per kilogram up to 200 mg versus intravenous sedation. Results of the study were somewhat unexpectedly. Study actually had to be terminated earlier because of unexpected finding of success, resource utilization, and difficulty in recruitment. But the results showed that intra-articular lidocaine group had significantly lower rate of successful reduction, only 48%, compared to 100% in a group who had intravenous sedation and analgesia. Patients in intra-articular lidocaine had significantly less satisfaction and, perceived by practicing physician, had significantly lower ease of reduction. However, both groups had similar lengths of stay and both groups did not experience any complications. Similarly, Orlinsky and colleagues conducted prospective randomized blind trial of 54 patients who were randomized to receive either intravenous sedation and analgesia with meperidine and diazepam or intra-articular lidocaine injection. Primary outcome, change in peri and post-procedural pain and degree of muscle relaxation and analgesic adequacy. Results showed the group who received intra-articular lidocaine, they were less effective in controlling pre-reduction pain. They had similar post-reduction pain in comparison to meperidine-diazepam combination. However, perceived on behalf of patients, patients suffered more with respect to analgesic adequacy and with respect to perceivement of practicing physician, intra-articular lidocaine provided less muscle relaxation. When it comes to length of stay and recovery time, group of patients who received intra-articular lidocaine had significantly shorter lengths of stay. Let me summarize everything. Intra-articular lidocaine provides decreased length of stay, decreased cost of treatment, and decreased complication rate. However, based on the data provided, there is some mixing, I would say conflicting data on peri and post-procedural pain relief and reduction success. In addition to it, patient or physician satisfaction rates. On that note, I'm going to thank you very much, and we'll see you next month. Hello, my name is Sergey Motov. I'm an emergency medicine physician at Maimonides Medical Center in Brooklyn, and today I am going to talk about a role of Propofol for treating acute migraine headache in the emergency department. I have no financial disclosure for this particular talk, and the reason I've chosen to talk about Propofol is that there have been a fair amount of literature, some controversial at times, that actually advocating and supporting use of Propofol for intractable or recalcitrant migraine headache. How does Propofol work? Propofol, as a known fact, it's an anesthetic. Does not really have analgesic properties. However, Propofol inhibits excitatory transmission, as a Propofol potentiates GABA receptors. In addition to it, Propofol inhibits NMDA and glutamate receptor. And lastly, administration of Propofol results in significantly decrease in central sensitization and cortical spreading depression. All of these facts mentioned above are postulated hypotheses why people get migraine headache. When should we use Propofol? 3 situations. It's a multi-drug resistant headache, intractable migraine headache, frequently recurring headache, also called recalcitrant headache. What is the dosing regimen? There are 2 ways of dosing Propofol for migraine headache. Number 1, you can use 10 to 20 milligram short IV push given every 5 to 10 minutes up to 1.5 milligram per kilogram of actual body weight or until pain is gone or optimized. Second way of giving Propofol for migraine headache is to use a full procedural sedation dose, such as given at 0.5 to 1 milligram per kilogram given as a single intravenous push. Now let's look at some of the evidence that support use of Propofol in treating acute migraine headache in the emergency department.
Too fast.
Okay.
And also, relax, move your hand.
Oh, okay.
Yeah. Start from the beginning. It's
Okay. Now let's review some of the evidence that support the use of Propofol for treating acute migraine headache in the emergency department. One of the first studies that evaluated value of Propofol for treating acute migraine headache was done by Cruz and colleagues and published in 2000. It was a 77 patients who enrolled in a study. It was prospective randomized non-blind trial where patients received 20 to 30 milligram of intravenous push of Propofol given with a frequency of 3 to 5 minutes, with the primary outcome of the study, change in pain score from the baseline at 30 minutes. Results showed that 95% of patients had significant reduction of headache at 30 minutes. 82% of patients had complete resolution of the headache. 18% of patients had a change in pain score between 50 of 80% of initial intensity. However, following follow-up phone interview of 24 hours after Propofol administration revealed that 3.8% of patients had a return of headache following treatment. None of the patients had significant side effects, and none of the patients required significant rescue analgesia while in the emergency department. Solomon-Poor and colleagues published a case series of 8 patients, 6 women, 2 men, with average age of 37 years of age who presented to emergency department with intractable migraine headache lasted for greater than 72 hours. This migraine headache was refractory to all possible analgesics that patient could have used. Propofol was given in a dose of 10 milligram every 5 minutes with average or mean dose of 60 milligram. Primary outcome change in pain score at 30 minutes, and authors did notice there was significant change in pain score from 9 upon arrival to 1 at 30 minutes among all the patients. 6 patients had an occurrence of headache at 24 hours. None of the patients required additional analgesia, and in addition to it, none of the patients required supplemented analgesia and had significant side effects. Further up, Solomon-Poor and colleagues conducted a prospective randomized double-blind trial comparing value or sub-anesthetic dose of Propofol given at 10 milligram every 5 to 10 minutes to intravenous dexamethasone at 0.15 milligram per kilogram with a maximum dose of 16 milligram in treating acute migraine headache in the emergency department. Patients who were receiving Propofol were given in addition 1 cc of 2% lidocaine per every 10 milliliters of Propofol to ease up pain of Propofol injection. 90 patients were enrolled in the study, 45 in each arm, and results showed that Propofol group had significantly better and faster change in pain score and better pain relief in comparison to dexamethasone group. Thus, at 10 minutes, change in pain score in Propofol group went from 8 to 5 versus 8 to 3 in dexamethasone group. And at 30 minutes, change in pain score in the Propofol group went down by 7 points in comparison to dexamethasone group, where change in pain score went down by 5 points. It took an average 10 minutes for majority of patients in Propofol group had relief of headache in comparison to 30 minutes of patients who received dexamethasone. Additionally, 2 patients in Propofol group desaturated to 89%, which was easily corrected with supplemental oxygen given via nasal cannula. Ward and colleagues published a case series of 15 patients who received Propofol on 22 occasions for control of pain and let's start this. Yes. Ward and colleagues published a case series of 15 patients who received Propofol on 22 occasions in order to alleviate pain for intractable migraine headache. Patient received 20 milligrams of intravenous Propofol every 10 minutes until pain-free. Interestingly enough, for this particular study, there were no restriction on adjunct medication. Thus, in addition to Propofol, patient received fluids, intravenous dexamethasone, intravenous metoclopramide, intravenous diphenhydramine, and intravenous ondansetron, as well as oral oxycodone. Median dose of Propofol for patients was 75 milligrams with a range of 20 to 140. A median time to get acceptable pain relief, such as change in pain score greater than 3 points, was 47 minutes. 85% of patients were pain-free at 45 minutes, based on the study protocol, and none of the patients required supplemental analgesia. Neither of patients had significant side effects. Mosier, just recently, published a case series of 4 patients who presented to Department of Emergency Medicine with intractable migraine headache and who received a full sedative dose of Propofol given at 1 milligram per kilogram. All 4 patients had drastic reduction of headache with complete disappearance of it upon awakening, with change in the medical rating scale from 9 to 1.5. Interestingly enough, the patients, 3 patients out of 4 patients, had at least 50% less with respect to timing of staying in the hospital after the procedural sedation compared to their counterparts who received standard abortive treatment for migraine headache. None of the patients suffer from hypertension, hypoxia, or apnea. Mosseni and colleagues just recently published a case report of a patient who presented to emergency room with multi-drug resistant and refractory migraine headache. Patient was given 60 milligrams of intravenous Propofol as a single IV push with a complete resolution of pain. Now let's look at children. Sheridan and colleagues conducted a retrospective chart review of children who presented to the hospital with severe migraine headache. They used data worth of 18 months, and patients who received sub-anesthetic dose of Propofol were matched towards the control of patients who received standard abortive therapy for migraine headache that includes NSAIDs, diphenhydramine, and prochlorperazine. 7 patients were included in the study. Those patients received sub-anesthetic dose of Propofol. Average dose of Propofol was 1.7 milligram per kilogram, which was given as a 10 to 50 milligram pushes. And results showed that compared to matched control, those who received standard therapy, patients who received Propofol for headache had significantly greater reduction in pain score by 80% versus 60%. Patients who received Propofol had significantly shorter lengths of stay, 122 minutes versus 203 minutes, and none of the patients who received intravenous Propofol had suffered from hypertension, had respiratory depression, or became hypoxic. Just recently, Roberts and Gnayem just carried out short review of 3 available trials and concluded that Propofol in sub-anesthetic dose actually might be feasible alternative for analgesic in patients with intractable or multi-drug resistant migraine headache. However, they cautioned people that well-designed trials further needed to clarify its role. Lastly, just recently, Mashtagian and colleagues published a randomized, controlled, double-blind trial evaluating efficacy in comparing intravenous Propofol given at sub-anesthetic dose to subcutaneous sumatriptan in control of acute migraine headache in the emergency department. 90 patients were enrolled in the study. Patients were randomized to receive 6 milligrams of subcutaneous sumatriptan versus Propofol, with initial dosing of 30 to 40 milligrams given as a single IV push, with a subsequent dose of 10 to 20 milligrams intermittent pushes to achieve level of sedation by using Ramsey agitation and sedation scale of 3 to 4. And results showed that the group of patients who received Propofol had a much better pain score at 30 minutes, which unfortunately disappeared at 1 hour and 2 hours, Group of patients in the Propofol group required less antiemetics and had less recurrence of the headache. Now, let me spend some time on talking about feasibility of using Propofol for treating acute migraine headache in the emergency department. And I'm going to refer to my colleague, Dr. Chris Bond, who is a Canadian physician, who published a very nice review on use of Propofol for migraine headache on his website at socmop.com. When you use or when you consider use Propofol for intractable or multi-drug resistant or recalcitrant headache, I want you to consider three things, or think about these three things. Number one, time commitment. Are you ready to spare 30+ minutes, on average 45 minutes, at the bedside of one single patient who needs to be on the monitor and who needs to be given medication with a frequency of 5 to 10 minutes in order to relieve its headache, knowing that the rest of the department is actually fairly busy? Number two, it's a well-known fact that deep sleep breaks pain cycle, does relieve any type of pain. And the question is, what if we just give sedative dose of Propofol to everybody? Yes, it takes a little longer to set everything up. Once one single dose is given, you don't have to be at the bedside and you don't have to give lots of medication with a frequency of 5 to 10 minutes. In addition to it, there's no data whether or not light sleep truly helps with reduction of migraine headache. And last point, which I believe even more important than anything else, is with respect to one study, we have no clear data on what is the recurrence rate of patients who are treated with Propofol in the emergency department and whether or not they come back with the same headache. What are the short or long-term consequences of treating patients with Propofol? What's the addictive potential for patients who receive Propofol, and whether or not in the long run those patients can turn to be habitual offenders or even become Propofol dependent. Thus, whether or not we open a Pandora box for those patients whom we're giving Propofol for headache. Those things should be considered when you're entertaining an idea of giving Propofol for patients in migraine headache in the emergency department. Let me sum everything up. If you ought to use Propofol for migraine headache, no indication for it. Not every migraine patient should be given Propofol. Only in situation where it's intractable, when it's lasts longer than usual, frequently recurring, or it's a multi-drug resistant, that's when Propofol is taking its place as an analgesic. Two ways of dosing Propofol. You can use small pushes at 10 to 20 milligrams every 5 minutes until pain is relieved, or you reach the dose about 1.5 milligrams per kilogram. Or you can just fully implement procedural sedation Propofol and use 1 milligram per kilogram dose. And please be aware of time constraints, sequel of therapy. And of course, as always I say, we need more robust, we need more controlled, more trials, more data with respect to full recommendation of using Propofol for treating intractable migraine headache in the emergency department. And on this note, I'm going to thank you again, and I will see you next month.